Good morning, everybody, and welcome in our beautiful city, Cairo. Let me give my appreciation to the European Association for the Study of Diabetes for the effort and everything done to make this course happen here in Egypt. This is the first time in Egypt, and we are very honored to have you all distinguished professors and speakers. Thank you very much, and for the audience, I hope you're going to benefit a lot from the course. Thank you very much, and now Professor Lezek.
Good afternoon, or good morning, everyone. My name is Leszek Czupriniak. I'm currently the chair of Postgraduate Education Committee of the European Association for the Study of Diabetes. And we're delighted to be able to come here. We, for the first time ever in Egypt, although it's not the first time we are in the Arab community, we are delighted to be here, not just because of this great city, country, history, your hospitality you're famous for, but also because that's one of the most important places for diabetes research and care. There is hardly any other place in the world where diabetes is more prevalent than in Arab Arab countries. So we try to be present regularly in this region, we call in Europe Middle East, but we also go once a year to the Gulf countries. Last year we were in Jordan. We also travel to places like Iran. Regardless of any politics, we simply talk to the doctors and meet doctors who look after the patients with diabetes. With your high prevalence of this disease in your country, I hope, as it was just said, you will benefit a lot, but we also learn as European Association what more can we do to work together more and for the improvement of health of our very numerous patients. The course is one of our regular activities. It's the last one we will have in this calendar year. We run 10, 12, up to 13, 14 courses per year. It's a lot of activities, also an effort on part of our part, local organizers, the faculty who comes here, and we always point out we are not paid for this activity. We don't get any honoraria. We do it as a kind of a service, and also being a part of the AASD. How important it is for the AASD, I have a very good piece of evidence, because the first talk will be delivered by Prof.Andrew Boulton, who holds almost all possible functions in the AASD, including the president. He's the immediate past president of our association. So as you can imagine how busy he is, he still finds time to take part in postgraduate activities. So this is a long-term project. In a way, we realize we started in the early 70s, and we will continue. And as I said, the places where we have so many patients with diabetes are always on the top of our agenda where we travel. The course consists of lectures and workshops. We strongly encourage you to stay with us for the whole duration of the course. The location is magnificent, probably too magnificent as for the meeting like this, because there's a lot of temptation to see the city, but you can always do it either, not in the breaks, but perhaps immediately after the course. We try to compile the program which will fulfill your needs. It was done together with local organizers. We worked on it. There are also local speakers. Feel free to ask any questions after the lectures or workshops. It's really as much as we could do and talk with you, answer your questions, discuss your experience with treating diabetes, all challenges, then we will know that we did something useful. So thank you very much for coming, and we're very much looking forward for those next 3 days together. Thank you.
Bismillah ar-Rahman ar-Rahim. It's a great pleasure for me the co-chair with the EASD postgraduate course, and I am very happy to find most of eminent professors in this field, and some of them I see them for the first time. I hope to have a good 3 days to know more and more about the diabetes and its complications. Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to thank this magnificent group of elegant speakers coming for free to teach, to help our patient, teach our doctors. It's a great pleasure to be with you in Cairo. Our first speaker is an eminent one. No ever event for diabetes, whether in EASD or whether it is in ADA or IDF, and Professor Boulton is always present and is always giving his magnificent lectures. His talk today about diabetes and obesity, the 21st century epidemic. Professor Boulton works and is a professor of medicine in University of Manchester, UK, and University of Miami, Florida, in USA. I don't know how he can manage, but please, Professor Boulton, your talk.
Shukran. Salam alaikum. It's a pleasure to be here in your country, and I'm somewhat ashamed to say it's my first visit here. And my first impression arriving at Cairo airport is that London Heathrow could learn a lot from you, because it's much more efficient. So it really is an honor to be here in this wonderful city, and I'm going to kick off with this talk on diabetes, the 21st century epidemic. Now, our former Chief Health Officer in the UK, Sir Liam Donaldson, said these words: "If you always do what you always did, you will always get what you always got." In other words, we need some change, and that's certainly true with our approach to diabetes, the global epidemic. And here is a paper some 8 years ago from the British Medical Journal talking about the global burden of diabetes. And it stated that for the first time in our history, non-communicable diseases have become the leading cause of global mortality and morbidity. This was 8 years ago. This is a world atlas, and you see here the physical geography of the world, and if this pointer doesn't work, so we're over there in the middle in Egypt, and you can see this is according to the physical geography. Now, if we change that map to the population distribution, we see a vast lot of people living really in Asia and also in the Middle East area. If we do the same for the diabetes distribution across the world, then we see a similar division with a huge prevalence of diabetes again in the Asian area, India, China, and it was felt then that India was number 1, China number 2, and United States number 3 in terms of global prevalence of diabetes. But it was this study from China that was published a few years ago in the New England Journal, a proper designed population-based study, that showed in red there that in 2007 to 8, just under 10% of the Chinese population were found to have diabetes. Now, if their population is 1.3 billion, that's 130 million people with diabetes. And the worrying thing was that many of these were undiagnosed were found out to have diabetes in this particular study. Here are some data that I found from your country, in Egypt. And it was reported 2 years ago that this was the 9th highest prevalence globally, that the prevalence of diabetes has tripled in the last 2 decades, and also in type 1. And the prevalence of diabetes in this country in the adult population was reported to be 15%, which is, of course, extremely high, and for your country it means a huge burden of chronic disease, and, of course, economically as well. I was just in August lecturing to the Pakistani meeting by Skype to Islamabad, and my good friend Abdul Bashit and Samad Sarah told me that they'd just completed their study looking at the prevalence of diabetes in Pakistan, a population-based study completed this year. And this is unpublished, and they're going to publish it, but the frightening facts were that 26.4% of the population in this study was found to have diabetes. This means that there may well be nearly 50 million people with diabetes in Pakistan. These are very worrying data. But it's not only type 2 diabetes, there is an ongoing increase of type 1 diabetes, and this study from Finland, which has the highest incidence of type 1 diabetes in the world, shows that this continues to increase. And these data published last year from the United States, a study of insured patients in less than 18 in young people with diabetes over 2002 to 2013, shows that the prevalence of diabetes had increased by 52% in the young population of the United States. Increase in type 1 diabetes was 57%. But we're beginning to see in the UK and the USA young people, teenagers with type 2 diabetes. And the prevalence of type diabetes in pediatric population was highest in the 12 to 18 age group. So it's a global increase of diabetes we're seeing type 2 and type 1. And if we look at these data here from a paper in Nature Reviews Endocrinology just last year, the change in the global numbers of diabetes between 1980 and 2014, look at this, a huge increase. And it's due to a number of factors, as you see listed here in the bottom right. Of course, this region of the world has some of the highest prevalences of diabetes. And when I travel, I like to pick up a local newspaper while they're still available, that is, before it's all electronic. And I was on the way to lecture in Dubai in 2011, and the leading page in the Gulf News, the national page, the headlines were the cases of diabetes growing faster than projected. This is in Dubai. But not only there, I was president of AASD, as my good friend Leszek said, for some years, and Düsseldorf is our headquarters, and I flew frequently from Manchester to Düsseldorf. And I picked up this here, a focus, De Sousa Falle, the sweet trap. So this is in Germany. A report here in a German magazine headlining diabetes as a huge problem in Germany, which is the largest country in population terms in Europe. So we have a war against diabetes, a global war. And during any war there are many battles, hopefully won, not lost. National, regional and global. So we need a national, international policy for diabetes to raise the profile of diabetes as a serious condition across the world that should be taken seriously. Now soon the next global atlas of diabetes will be published at the IDF. These are the data published in Vancouver just under 2 years ago at the IDF meeting. And look at the projections that are already an underestimate. 1 in 2 adults with diabetes is undiagnosed. And adults who died for diabetes, as a consequence of diabetes, 5 million are there, which is more than those dying from HIV, AIDS, tuberculosis, malaria, infectious diseases. So this is a global problem. So there is an urgent global need for policies that promote prevention, primary prevention. Can we identify high-risk groups and prevent them from going on to get diabetes? Secondary prevention. Those patients who already have diabetes, can we prevent the late complications from developing, and so on. This was a paper by my friend Professor Ronald Marr and colleagues from Hong Kong, published last year in Diabetes Care, the global burden of diabetes. The rise of type 2 diabetes in South Asia was predicted to be 150% between 2000 and 2035. They described this as a rising global public health tsunami. So, messages that we need to give to governments and the world at large is that we cannot afford to ignore diabetes because the human and economic costs will be too great. Diabetes consumes up to 15% of national healthcare budgets. In some countries, it's as high as 40%. Of course, a large part of this is due to the late complications, which we will be discussing. Now, I was very fortunate last year to share the stage in Bangalore, India, with the Prime Minister of India there on the left, Sri Narendra Modi. And he was an impressive speaker. He got up and said to this audience of 15,000, no longer are malaria and tuberculosis the biggest threat to our survival as a nation. It's diabetes and chronic diseases, non-communicable diseases. And he's right. So in some countries there is a realization that we need to act now to save catastrophe later. And here we see an atlas again, looking at the prevalence of raised blood sugar aged 25 years and above in females. And you see the highest prevalence, again, in this region, red and brown. And this coincides with the prevalence of obesity. Again, it's not just the countries around here, North America, even Iceland there, surprisingly. Now, it was some years ago that this article appeared in The Age, which those of you who've been to Australia will know is the national newspaper in Melbourne. And this was when our good friend Professor Paul Zimmet was starting his studies of the Polynesian islands, looking at the distribution of diabetes. And this was the headline, "A Western Killer Let Loose in Paradise." Now, I don't want you to think that Professor Zimmet's in prison for mass murder. Of course, the Western killer is diabetes. And the island of Nauru is a classic example of where the prevalence went from nearly 1% up to about 35% with coca colonization, if you like. And he talks about coca colonization of the world, acculturalization, modernization, and contributory factors are seen here. Again, if you look at the age standardized prevalence of obesity in all age groups, but worryingly at the bottom in children, we're facing a global disaster. Obesity in children is rising. Now, this gentleman is sitting on a fire hydrant, as you see at the famous Wrigley Field in Chicago. And this is what we call a diabesity epidemic worldwide. A large prevalence increases in both nations, both developed and developing, due to social, environmental changes, globalization, if you like. And it's one of the biggest and most serious challenges to public health in the 21st century. Now, looking at this gentleman here, sitting on that fire hydrant, I was worried about the safety of the fire hydrant, actually. It was quite a large BMI sitting there, and I was worried that he might end up getting a large enema if there was a burst pipe. But apparently he survived. Now, look at the, if you like, the competition. at the bottom there, and you have to say that the USA is probably the most generous in funding for research in diabetes. And therefore the budgets for the Center for Disease Control in Atlanta, for the FDA, about $6.4 billion. But look at the opposition. Advertising spent on food, confectionery, beverages, cars, 4 times more. And of course, this promotes sloth, if you like, in other words, not doing too much. Here is a headline in the British Medical Journal some 15 years ago. Obesity is an epidemic without treatment. And here, if you like, is the development of mankind to McDonald's man in the 21st century. This has to be in the United States, and I think one could not doubt that this is true. If the gentleman did have anorexia, then he certainly got over it. And this, if you like, is the ultimate in inactivity. How to walk your dog, drink a Coca-Cola, and watch television without expending any energy whatsoever. And this is the problem we're facing. So, obesity, diabetes, there is a genetic vulnerability. Insulin resistance, impaired glucose tolerance, as you know, hypoglycemia leading on to diabetes. But there are opportunities for intervention, for prevention, all the way along: prenatal care, adolescence, adulthood, maternity, old age. At every step in our lifetime, there are possibilities to reduce this huge impact of disease. Here's a paper this year, Childhood Obesity and Analysis in 200 countries. The Global Obesity Childhood Study that shows increases, huge increases in obesity in girls and boys. Huge increases. Despite this, having said that, across the world more people remain moderately or severely underweight, for example, in sub-Saharan Africa. So there are opportunities for intervention in early life: weight management, preconception, pregnancy, postpartum, gestational diabetes, childhood obesity prevention, and so on. So obesity and pregnancy are associated with insulin resistance and inflammatory changes. So overnutrition, maternal obesity, fetal lipid exposure, and so on. This is a paper published a few years ago. So we need to start, if you like, preconception, if we're going to tackle this problem of childhood obesity. There was a study from Finland in a city which I will not even attempt to pronounce that showed a mass program in one small town had a huge impact on reducing childhood obesity. Here's another study called the Boris study. It's not our friend Boris Mankowski, I don't think. This is showing that obesity treatment in childhood can be effective. And you can see in all age groups a reduction in this program, and published in a pediatric journal last year. There are opportunities for prevention of diabetes and early intervention in later life too. Screening, targeted screening, family history, obesity, previous gestational diabetes, and so on. Bariatric surgery we will hear about later in this session. Advances in diabetes treatment and screening, early intervention. Look at the studies from Finland and the diabetes prevention program in the USA, highly effective. But we need to do something about this, and this is a paper I picked up on the way back from lecturing in Calcutta last year. This was the Times of India. Stop the hard sell of sugary drinks, sugar-coated danger. The prevalence of diabetes, this open letter to the chief executives of Coca-Cola and Pepsi-Cola in India, said that the prevalence of diabetes in India has doubled in 12 years. Can we please stop trying to promote what seem as sort of very attractive drinks loaded with sugar and loaded with danger? So here's perhaps a rhetorical question. Can we educate our politicians? Well, you may be surprised to hear, but Mexico is doing well. They put a 10% tax on sugary beverages. So far, so good. There's a reduction in sales, and they're beginning to see a reduction in obesity. Denmark, on the other hand, you may be surprised to hear, failed. And I was at an international meeting in Copenhagen when the then Minister of Health announced the introduction of a sugar tax. But it failed. It wasn't implemented. And people could get on the train at Copenhagen, and an hour, 15 minutes later, they're in Sweden, they buy the food and come back, avoid the tax. It failed. In Berkeley in California, a 25% tax was introduced in 2015 on high carbohydrate beverages, led to a 21% reduction in sales. The UK, well, it's always next year. And they're saying next year, 2018, we will have a tax implemented again on high sugar content sodas, if you like. So there is some hope, but taxes must be accompanied by other policies, such as advertising bans and implementation. Now, an example of what went on in the UK was that when Tony Blair was Prime Minister, he got together with a famous chef, I think it was Jamie Oliver, and they said, we're going to do something at schools, because in schools they have what you call a tuck shop, where you can buy high carbohydrate snacks, cookies, cake, crisps, high sodium, Coca-Cola. They said, we're going to replace this. We're going to remove them and have a high fiber diet, specially designed by this chef, brought in, so they're using a lot of vegetables and healthy foods for lunch, and you can't buy these things from machines in the school. Very good idea. A week later, in the Daily Mail, which I wouldn't really recommend to you, but there it was on the front page, pictures of mothers selling fish, chips and mushy peas through the railings of these schools because the children did not like the high fiber diet. So we have to start early and implement. We have to have parents on the same page fighting with us. Global diabetes epidemic. Here's an update from this June from a paper in Lancet Diabetes and Endocrinology. The global cost of diabetes in 2015 was 1.3 trillion US dollars, or 1.8% of global gross domestic product. 2/3 of these costs were direct, but a third were indirect, such as lost productivity, etc. In the United States, this paper showed from Ed Gregan at CDC that of all conditions, diabetes creates the largest costs for the healthcare system. So the days of inactivity really cannot go on. We need to be proactive. We need associations like EASD, like ADA, but particularly like IDF, to be the global spokesperson for diabetes and to be seen and heard acting together as a team, working together. Now, having said all this, unfortunately no study has shown that diabetes can be delayed or prevented in a community setting. They've shown it in highly interventional studies, such as the Finnish Diabetes Prevention Program by Jaakko Toimalito, that showed clearly, as the DPP does, you can reduce diabetes by intense activity, dieting, but you don't need to go to the gym. Just walking 45 minutes a day may well be sufficient. So the clinical trials on community-based have not shown a beneficial effect. But this doesn't mean that it doesn't work. As I will tell you in the diabetic foot, I cannot prove to you that education reduces the incidence of foot ulcers. But we intuitively believe it does, and the study will never be done, as it will be unethical not to educate people. So let me be provocative and ask this question. Is diabetes the cancer of the 21st century? We can learn. I'm not criticizing our colleagues in cancer medicine. We should be learning from them, emulating them. If you think about it, they're highly effective in screening high-risk groups. People will go for a prostate check, for a mammogram, because they're frightened of cancer. Cancer's serious. Cancer kills you. Long-term remission and cures are possible in cancer. Similarly in diabetes, so we should learn from them. Increase public awareness. Now, I bet if you were collecting money outside this room, even at a diabetes conference, one person had a bucket, cancer research, give Egyptian pounds. Another one, heart disease. Another one, diabetes. Out of £100, probably 90 would go to cancer. 8 to heart disease, and if you're lucky, 2% might go to diabetes. So people don't take diabetes seriously. So, my God, I'm going to be screened for cancer. That's terrible. But diabetes, my mother had, she was fine. She died at 93, a touch of sugar. Nothing to worry about. Not true. My group in Manchester, we've published longitudinal data to show that if you have end-stage renal disease because of diabetes, and you've had a foot problem and lost part of a foot or a leg, 75% of those people are dead within 2 years. 75%. That's worse than every form of cancer, except perhaps lung cancer. So we need to change our approach to diabetes, to take this as a serious, threatening disease that can be prevented. If you've got it, you can prevent getting late complications, but we need to be proactive. And in the cancer world, fear arousal has worked. People are frightened of cancer, so they'll go and have a screen. Why do people take a statin for heart disease? They don't feel any better. They're frightened of having a heart attack. That kills you. Why don't people go for a screen for diabetes and say, oh, it's a touch of sugar, nothing to worry about. Nothing serious. We've got to change that approach, but it's still prevalent across the world. So fear arousal has been effective in raising money for research in diabetes. So I think we need to change our approach. And large organizations like IDF, EASD, and ADA need to be leading this battle to change the psychological approach that diabetes is actually a life-threatening disease that we can do a lot about by preventing, primary prevention, secondary, and even tertiary prevention. So we have a challenge facing us in type 2 diabetes, and the challenge isn't simply treating the blood sugar in the bottom there. There are many challenges. Can we preserve beta cell function? My center was one of the centers in the UK PDS, and we showed bottom left that 50% of all patients presenting with type 2 diabetes are hypertensive. So it's not just the blood sugar, it's the blood pressure, it's the lipids, the cholesterol. And then how do we address compliance or adherence? How can we encourage people to take medicines that may not make them feel any better, like a statin, like a beta blocker, like an ACE inhibitor? Can we prevent and delay complications, large vessel and small vessel, and so on? So it's a very complex approach. So I'll leave you with this thought from Enrico Fermi, and I hope it does not apply to you. It says here, before I came to your lecture I was confused. Having heard it I remain confused, but at least at a higher level. So, shukran.
Thank you very much, Professor Andrew, to speak about the challenges with type 2 diabetes prevalence and the increasing prevalence. Thank you very much. Is there a question or comment? Just in few minutes.